I hope everyone had a little nosh and an opportunity to visit the community organizations that are set up in the hallway. Just to give you an idea of the time and the effort that went into this event. Symposium is a product of 6 months of hard work by countless individuals and by many sponsors. These gems of our community have a common goal, and that is to educate as many people as possible about the BRCA gene mutation and risk for cancer in Ashkenazi Jews. This symposium is a call for action to enhance the knowledge of the BRCA gene, allowing each of us to take responsibility for ourselves and our families. It really comes down to one thing, and that's saving lives. Through education and knowledge comes power. We need 3 things. We need awareness. We need to learn who has an increased risk of carrying the BRCA mutation. Historically, BRCA was believed to affect only women. However, that's no longer the case. We need education. We need to understand the process of genetic counseling and genetic testing. Lastly, and most importantly, we need action. We need to develop strategies for talking about genetic risk and test results, not only with families, but with our doctors. Before we get started, I'm going to ask that everyone take their phones and put them on vibrate, turn them off, whatever they need to do, so we have a smooth morning. I would like to recognize and thank the following. Temple Shomer Emunim for once again opening their home to the Jewish community and providing a venue for this important event. Arlene Levine, director of the Toledo Jewish Community Foundation, who has been such a wonderful collaborator. This program would have never gotten off the ground without the unbelievable support of all the committees, sponsoring organizations, and community cancer support organizations. Rather than calling on these individuals and organizations at this time, recognition will be listed on the back of the call to action handout that we will receive at the conclusion of the program. When you get a moment, thank them for an incredible job well done. Last but not least, I would like to thank the Sidney Mostov Memorial Fund of the Jewish Community Foundation for generously underwriting this program. At this time, I would now like to call on Diane and Alvin for a few special remarks.
Good morning. I'm Diane Mostov Alvin, and I'm Sydney's daughter, and I'm here with my sister Patty, who came in from Colorado, my brother Michael, my husband Marty, and my brother Stephen is in California, couldn't make it here. Some of my other Gross family relatives are here as well, because this is an issue that has impacted all of us. My father was Sidney Mostov. He loved the Federation and spent most of his life working for it, first as a volunteer, and then at age 60, he was hired to work in development, giving him a second career. He would be so pleased that the Federation is using his memorial fund to host this important event. My mother, Joanne Gross Mostov, died of breast cancer at age 49. Her 2 sisters, Paulette Gross Green and Marilyn Gross Eisler, also died of breast cancer before they were 50. My grandfather had died of cancer when he was in his 60s. Naturally, only Dick Gross was a surviving sibling in that family. Naturally, I, my siblings, and my Gross family cousins felt we were doomed by a family curse and wouldn't live to see our 50th birthday. Then along came genetic testing. In 2000, I went to the Carmanos Cancer Institute in Detroit, where I live, and went through genetic counseling and testing. At that time, genetic testing was very new, and there were many concerns about whether insurance would cover it, and if you could lose your insurance if it turned out that you were positive. Luckily, I had really good insurance and a secure job, so I was the first in the family to get tested. Not surprisingly, I tested positive for the BRCA2 gene. That just confirmed what we had all suspected. There is a genetic curse that runs through the family. That testing turned out to be very helpful in making subsequent decisions about prevention and treatment. The testing helps you and your doctors make much more informed decisions. Subsequent to my getting tested, other family members got tested as well. Some tested negative, which was a great relief to them and their children, though no guarantee that they wouldn't get cancer. Those who tested positive are given intense preventative scrutiny. There is still a family curse, which has sadly affected my generation. Some of us have been diagnosed with breast or prostate cancer, but are doing fine. One cousin, Debbie Eisler, died after a long battle with ovarian cancer. Thanks to genetic testing, we are confident that the curse stops here. The next generation should be safe. The ironic and amazing thing is that when the Federation decided to do this program using the Sidney Mostov Fund to help underwrite it, they had no idea about our family history and how appropriate it is that we help sponsor this event. I think there is a Yiddish word for this, beshert, or meant to be. Thank you so much to Arlene, Faggy, Beth, and the planning committees for all of your efforts to make this happen. Thanks to all of you for coming and participating. We are very grateful.
Thank you very much. Indeed, we are so lucky to have three passionate panelists with us this morning. I'd like to introduce Gayle Retzke. She's an ovarian cancer survivor. After preventative surgeries, Gayle has become an active, passionate speaker and advocate for ovarian cancer and gene testing. Dr. Michael Gordon is a rheumatologist specializing in arthritis and autoimmune diseases. He will share his journey about testing positive for the BRCA gene mutation. Mike will share the impact it has had on his life and give the unique perspective of testing positive for a gene that historically was thought only to affect women. Dr. Iman Mohamed, an oncologist at University of Toledo Medical Center, an expertise in BRCA gene mutation. In addition to the outstanding credentials, Dr. Mohamed's connection to the Jewish community is legendary. 16 years ago, she approached us with a message, and I quote, "I need to access the Jewish community to educate and raise awareness on breast cancer. Ashkenazi women are at much greater risk than the general population. Early detection and ongoing screening are critical to the Jewish community." This is Dr. Mohamed's 5th time presenting to our community. We are so lucky to have her here with us today. The structure for this morning's event will be as follows. Dr. Mohamed will introduce the program and set the stage for BRCA gene and the associated cancer risk. This will be followed by Gayle and Mike, who will share their personal stories, after which Dr. Mohamed will summarize and give a brief lecture. Not to worry, there will be plenty of time for questions afterwards. I ask that you write your questions on the paper provided and to whom you're asking the question. Towards the end of the symposium, your questions will be collected and presented to the panel. Without further delay, I would like to introduce Dr. Iman Mohamed.
Thank you, Dr. Zack. Good morning, everybody, and thanks for the warm welcome for the 5th time again. What I'll do in the first 2 to 3 minutes is go over the take-home messages, and then as the program unfolds, you will see these points come over and over again. And as Dr. Zack said, as you leave, you're going to take these take-home messages with you. The first thing that we all need to think about is, I truly loved Ms. Mostov's remarks. What I liked the best was that the curse stops here. The curse needs to stop. We need to think of it as an opportunity for a blessing. The time cannot be any better, the knowledge is available, and there's no need for loss of life. This can be definitely avoided smartly. So, knowledge of the family history is power, and it saves lives. Both sides of the family matter. Mom's side of the family as well as dad's side of the family. The next point is know your family history, if you can. A lot of people in the room may have family members who were lost during the Holocaust, or have smaller families, or just are scattered all over a country that really spans shore to shore, almost a continent. So you may not know all the details. So share, if you can, and ask, because sometimes people are not willing to share some of these details as they're dealing with the disease themselves. What are the red flags? What are the things that we need to be paying attention to? It could not have been said any better. 3 individuals in the same family who were diagnosed with cancer less than age 50. Cancer in general is a disease of older individuals. As we get old, our cells forget how to divide accurately without making mistakes. So mistakes happen, cells look bizarre, and that's what cancer is. Cancer is not a germ, it's actually one of the cells in the body that divides and looks eventually different from what the original source of the organ itself looks like. So what makes these individuals present with tumors that are early in life is they've inherited a tendency whereby the cells are not able to make corrections to the mistakes as the cells divide. And I'll talk a little bit more about that. But the take-home message is, if you know of family members, more than one, who were diagnosed less than age 50, 50 seems to be the magical age, then you need to at least sit down with somebody and discuss your family history. Doesn't necessarily mean testing, but at least counseling. So that's the second point that needs to be paid attention to. The third point is paired cancers or cancer in more than one organ. So if you hear of a family member who was diagnosed with bilateral breast cancer or breast and ovary, that's not unusual. You think that it's unusual? It's not. I have 5 or 6 families in my practice that have both breast and ovarian cancer in the same individual. These are red flags. You need to sit down with somebody and talk to them. Testing is nothing complicated. It's really a blood sample. There are 2 ways of doing this, either taking a blood sample or a buccal smear, scratching from the inside of the mouth. The blood sample is a much better way to do this. It is covered by insurance. Where I do this at the University of Toledo, we never send the specimen out without checking with the insurance company. Sometimes there may be a copay, and we talk to our patients. You know, if we're born with our genetic makeup from the day we're born. So if it's better for you to get tested at the end of the year when you don't have to pay your copay, there's no rush. We don't really need to test in March. We could always wait until December at the end of the year when you don't have to pay a copay of $600 or etc. So it is a blood sample. We don't send the blood sample out to the company that tests without verifying health coverage. And most insurance plans, and that's something for you to know, most insurance plans cover this, and HIPAA prevents me as a physician from disseminating genetic information to anybody other than the individual that you as a patient or somebody who is worried well. You don't have to be a patient, you could be somebody who's concerned. As I will explain later, I will not disclose this information, neither will my office, to anybody other than somebody, including your family members, other than somebody that you want me to disclose this to. And I'll leave it at that day for now, and then we talk.
Very good. Thank you very much. I would now like to introduce Gayle. She will discuss the very personal aspect of BRCA gene and cancer in her family. Gayle?
Probably have to lower this. David, if I go on too long, just get the hook out, because I could probably talk for 3 hours. I'm Gayle Retzke. I'm BRCA1 positive. I thought I had a normal life when I was growing up. Grew up in New Jersey. I have an older brother, and I had an older sister, and my life was wonderful until I was a teenager, found out that my father was working for the mafia. But that's another whole other story that won't go into here. During that time, my sister was my protector, and she would get me out of the house because our phones were tapped by the FBI. It was a big mess. And so my sister got us out of the house, and I thought it was wonderful because I was hanging around with my older sister. Then she came out to Ohio State, and as a senior in high school, I came out to see her. And not only was she my protector, but then she became a matchmaker because she introduced me to my husband, Bob, and got married, came to Toledo, was living what I thought was a charmed life, lived in St. James Wood. My 2 kids go to Central School, Parents Club, the whole 9 yards. And then I get a call from my sister, who had since moved to Australia, which is another long story. And she tells me she has ovarian cancer. Okay, she said she was going to be fine. Don't worry about it. The doctors knew what they were doing, and she was going to be fine. So I don't know if I believed her because I wanted to believe her or whatever, but about a year later, I get another call from my cousin, who is a doctor out in the state of Oregon, and she said, listen, A couple of cousins were getting tested for this gene called BRCA to see if it runs in the family. And so I said, all right, you get tested, I'll get tested. You know, it's a blood test. So Bob and I went up to the University of Michigan, and we met with a genetic counselor, and they told us all the options and what to do and what could happen. And this is serious now. I mean, this is not good. I had taken Bob as my support, but I had to drive home. He was just devastated. Probably because he's smarter than me and he knew that this was really serious. And so that started the whole process. We met a lot with the genetic counselor up at the University of Michigan, who is a wonderful person. She gave me all the options, never told me what to do. I could go on tamoxifen and to prevent cancer. I could be screened for both ovarian cancer and breast cancer periodically, or I could have surgeries and take out parts of my body that did not have cancer, but could potentially have cancer. And I thought about it for about 3.5 minutes, and I said, I cannot live with, an 80% chance of getting breast cancer, a 60% chance of getting ovarian cancer. It's just not my style. And to be honest, I knew that Bob would be a basket case every day, because he's a worrier. So he would worry enough for the two of us. It just wouldn't be a good life. So I said, I don't need my breasts, I don't need my ovaries, just have fun. So we went back to the University of Michigan. I had what they call a salpingo-oophorectomy, which means they took out my fallopian tubes and ovaries because they believe that ovarian cancer starts in that area, just those two parts of the body. That was outpatient, that was relatively easy. That was July of '01. Met with plastic surgeon up there, met with everybody. It's sort of surreal. You're going through the motions, people are telling you what to do, and it's like it's not really happening to you. It's a movie. And then in February of '02, I had double mastectomies, and I opted for what they call a tram, meaning they take two muscles from your abdomen and they loop it through your body somehow, and then they reconstruct your breasts starting out with these muscles. I did not want implants. I was told I would feel like a Mack truck hit me afterwards. Oh my gosh. Recovery was horrible, but that's because I can't take narcotics. So I was on ibuprofen after having double mastectomies. And my abdomen cut open. It was not fun. In the meantime, my sister, who's living in Australia, comes over once a year and seems fine other than losing her hair. And we have fun. We go to Florida where my mother lives. We go snorkeling. What I didn't know was that she stopped her chemo weeks beforehand against her doctor's orders so that she could have her body heal for a few weeks and be fine when she came over here. She was fooling us. She was trying to save us from knowing what was going on. I yell at her to this day for doing that because, you know what? Had I known, maybe I would have been in Australia or called her more or whatever. So 5 years after she was diagnosed, she went through all these chemos, and the last one she took was an experimental one in Australia that the FDA did not approve here, and it literally burned the skin off the palm of her hands and the skin off her tush, and eventually burned her intestines apart, and she passed away. There went my protector. So that was in '04, and as you can tell, I still haven't gotten over it. But you know what? She actually still continues to protect me. Because had Karen not gotten ovarian cancer, I would not have known about the BRCA gene. I would not have been tested. My cousins, when they had the surgeries, had stage 1 ovarian cancer, which they would not have known, so they were able to take care of it, because ovarian cancer is very treatable at an early stage. The problem is, the symptoms are so, normal to a woman especially, that we ignore those symptoms and are not, we're not detected until we're at later stages. So I sort of feel like my sister has still been my protector to this day, because more recently, my daughter tested positive. Children have a 50% chance of testing positive for this gene, and she just had her double mastectomies in Florida last December. The worst day of my life, sitting there for 9 hours with Bob in the waiting room when the surgery was only supposed to take 6 hours. No one coming out and telling me what was wrong, or if there was something wrong. And about the 8-hour mark, those of you who know me will understand and know that I did this. I went up there and said, I know there's a phone in the operating room. Somebody call there and find out what's going on with Heather. Or you better call the police because I'm marching in there. I dropped a few choice words at the moment. I mean, I was frantic. So that's when they came out and told, oh, we're fine. There was just a lag between, the surgeon and the plastic surgeon. There was a time lag in there, and that's why it's going longer. So Heather did the mastectomies, and now at 40, she has to decide whether to have the oophorectomy or hysterectomy. And she's sort of putting that off, so when I go down there in December, we're going to the doctor together and we're going to have this long discussion. I think out of my whole experience, what I want you to go away with is, number one, we all have to be proactive. There are bodies and there are lives. Yes, we go to doctors and we listen to what they say, but we all have to be knowledgeable. And if we feel there's something wrong or we want to be tested, you have to demand that you're tested. You cannot just walk away saying, oh, the doctor thinks it's fine, so I'm going to ignore all these other red flags. I think that the surgeries are not for everyone. There are alternatives. I could not live with those alternatives, so for me, the surgeries were important to have. I also want you to know that this is not just breast and ovarian cancer. Let me continue with what studies are saying now and what they're studying and don't really know about for the future. I was contacted by a research group in Seattle. They were studying the link between melanoma and the BRCA gene. My father had melanoma. All this BRCA gene was on my father's side. They concluded, after studying this, that there is a link between the BRCA gene and melanoma. Okay, so now I don't go in the sun, I wear a big hat, I love the beach, I sit under an umbrella, I don't wear a bathing suit, I wear, pants and a t-shirt or whatever. There also there's also the prostate cancer, there's the colon cancer, so men are greatly involved with the BRCA gene, and Mike will talk more about that. They are also studying lung cancer, they're studying thyroid cancer. My cousin had lung cancer, the one that tested positive and had stage 1 ovarian. I had to have my thyroid zapped, with a pill. So who knows where this lovely gene, will take us. It is not something to be ignored. So I hope everyone, it's not something to be scared of, but it is definitely something to be aware of. So I thank you.
Well, thank you very much for those words. Dr. Mohamed.
His message, despite the fact that may sound to some like an alarmist message, but I don't think that one can ignore the survivor spirit. So Gayle is a pro-vivor because Gayle is proactive, and she took matters in her hand and prevented 2 malignancies for which, true, there is a treatment, but she actually cut down the risk significantly by her choice of having surgery. I like the fact that she discussed that there are other options, which we will go over as the program unfolds. So best to you and your family.
Great, thank you very much. At this time, I'd like to introduce Dr. Michael Gordon, who will share his recent journey.
So my story is slightly different than Gayle's. There's no history of breast cancer in my family, and there's no history of ovarian cancer in my family. So you might ask, well, how did you find that you had the BRCA gene? Well, that's a very good question. So what happened is, my mother has one brother, Erwin, and he and his wife had 2 normal children, and their 3rd child was born in the early 1960s with a bunch of malformations and birth defects. This was my first cousin. She lived for about a year and died, and at the time they had no idea what was wrong with her. They figured maybe my aunt became pregnant, developed a virus during pregnancy, and it was some type of random thing. And nothing happened for a number of years, but then about 30 years later, in the around 2000, my mother's first cousin, Adele, had a grandchild that was born with the same kind of birth defects. So somebody put 2 to 2 together and realized that these 2 events were linked. And they subsequently did a testing and found that my cousin and this other cousin had a condition called Fanconi's anemia. And it was discovered in 2001 that Fanconi's anemia was caused by the BRCA2 gene. So they decided to do genetic testing on my family, my mother's side of the family. My aunt and uncle were both tested, and they each had the BRCA2 gene. They had a different gene. They each had a different mutation of the BRCA2 gene, and Dr. Mohamed could probably talk more about the different types of mutations with the BRCA genes. And then it was decided that my whole family should be tested, and my family lives in New York, and they went to Sloan Kettering Hospital in New York, and my mother was tested, and she was found to have the same gene as my uncle. And my 2 brothers who were living in New York at the time were also tested, and one of my brothers tested positive, and my other brother tested negative. So I was living here in Toledo at the time, and we decided that I should get tested, because primarily we were concerned about my daughter, who was 23 at the time. She was just starting medical school, and we were concerned about the risk of breast and ovarian cancer. So I actually went to Dr. Mohamed, and she saw me, did a whole workup, and I was tested, and I was also found to be positive for this BRCA2 gene. And at the time she told me, so for men, the risk of BRCA2 genes was there was an increased incidence of male breast cancer, and there was also a increased incidence of prostate cancer. And testing on my family, my mother's side of the family, my aunt and uncle were both tested, and they each had the BRCA2 gene. They had a different gene. They each had a different mutation of the BRCA2 gene, and Dr. Mohamed could probably talk more about the different types of mutations with the BRCA genes. And then it was decided that my whole family should be tested. And my family lives in New York, and they went to Sloan Kettering Hospital in New York. And my mother was tested, and she was found to have the same gene as my uncle. And my two brothers who were living in New York at the time were also tested, and one of my brothers tested positive, and my other brother tested negative. So I was living here in Toledo at the time, and we decided that I should get tested. Because primarily we were concerned about my daughter, who was 23 at the time. She was just starting medical school, and we were concerned about the risk of breast and ovarian cancer. So I actually went to Dr. Mohamed, and she saw me, did a whole workup, and I was tested, and I was also found to be positive for this BRCA2 gene. And at the time she told me, so for men, the risk of BRCA2 genes was there was an increased incidence of male breast cancer, and there was also a increased incidence of prostate cancer. Now my uncle, who was the father of my cousin who had died with Fanconi's anemia, also had developed prostate cancer in his 60s. So I decided that I should be tested regularly for prostate cancer. So I started having my PSA checked. This was about 2004, and I went every year, and so I was seeing a urologist. And initially my PSA level was normal, but what happened is about 2009 my PSA started going up. So my urologist recommended that I get a prostate biopsy, which I did, and it turned out to be negative. So I was relieved about that, but he said we need to keep checking your PSA, and I checked it again, and after 6 months, and it continued to go up. And to make a long story short, I ended up having two more prostate biopsies, and they were all negative. So we're thinking, well, what's going on here? Do I have prostate cancer? Or because some people can have an elevated PSA and not have cancer. So then in December I had another PSA, and it had gone up even further. So I decided to get a second opinion, and I went to Cleveland, and I saw a different doctor, and they did some additional testing and found out that I did indeed have prostate cancer. And in April I had my prostate removed, and fortunately I was able to be cured. The cancer was completely removed, and my PSA is now non-detectable. So subsequently my daughter was decided she wanted to get tested, and turned out that she tested negative. So that was a relief. Now my mother, who was positive, that she was in her 70s when she was found to have the BRCA2 gene, and she decided to have her oophorectomies, but decided not to have mastectomies. My mother is 85, and I'm happy to report that she is cancer-free. And as I said, there's no history of cancer, breast cancer or ovarian cancer in my family. So, but there is the prostate cancer. So for men, it's a different situation. Prostate cancer is very common, and it's if you knew that you were BRCA positive, it would be recommended that you be monitored carefully for prostate cancer and also for male breast cancer. I check myself all the time. So that's my story.
Dr. Mohamed, a little bit of a twist, a little more unique. Can you give us some words, please?
So the 2 points that stand out in Dr. Gordon's story is the word that he said at the beginning. Somebody put 2 and 2 together. Now, I have autism in my family, and it took us many years to put 2 and 2 together across different generations, just a little bit here and there. So it's very hard sometimes to put 2 and 2 together. It's very hard sometimes to put 2 and 2 together when you're in the middle of this. But somebody took the time, somebody was smart enough, somebody was brave enough to link these 2 individuals who are young, who were diagnosed with Fanconi's anemia and multiple genetic abnormalities. That's number 1. And number 2, the positive message that Mike talked about is not all families are exhibit the whole syndrome of breast and ovarian cancer. In his family, there were not a lot of breast and ovarian cancer, despite the fact that it is still the BRCA2 gene. And that's due, Mike, to the presence of protective other genes in the family. So that's the other side of the coin, is testing empowers you, but it doesn't necessarily mean that everybody will develop cancer. And at the end, I was very happy that his daughter got tested. Now, thank God that she was negative. Now, I actually don't like testing 23-year-olds. She probably was 25 or maybe 35 or maybe 30 something by the time she got tested. Or was she still?
She was a first-year medical school
Yeah.
at Ohio State, and she decided she wanted to
To get tested. Yeah, so that's a mature individual. Sometimes 22-year-olds and 20 news is testing is approved for adults. So technically anybody above 18 can be tested. There are some genetic mutations that Dr. Zack deals with, mostly in colon cancer, that we end up testing kids who are very young because cancer can happen before the age of 40. But for BRCA2 and BRCA1, testing doesn't necessarily have to be offered to children. The best news is this young lady who's starting her career decided to get tested, and she found out that she is not a carrier of a mutation. It's only 50% of offspring of children of a carrier that will actually carry the mutation, and that doesn't matter if the gene comes from mom or dad. And by doing so, she's not going to be getting mammograms and MRIs on a regular basis starting at the age of 30 or 35. She will still need to get mammograms as usual as any other woman, because being a woman makes you at risk of breast cancer. But she doesn't need to have either cytoreductive surgery, meaning that she does not need to have breasts removed or ovaries removed, and she does not need to be on medication. Testing empowers, and knowledge of the family history empowers one.
Very good, thank you very much. And Dr. Mohamed, some additional words?
I'm so glad, David, that we decided to have Gayle and Mike share their stories, because I think within the stories there were a lot of valuable information that I will not spend a lot of time going over some of these points, but I'll highlight certain things that we need to know about. Genetic material does not die. That's why we're talking to your community today. Especially in a community like the Ashkenazi Jewish, where in your background, just like mine, I would want my children to get married to individuals who are Muslim. I understand very well, if you are a Jewish individual, that you would want your children to be married to somebody who's Jewish. Jewry is not just a faith, but it is also an ethnic background. There was a time more than 5,000 years ago when Jews were the only believers in one God. So, needless to say, after the breakdown of First Temple, when they fled to Europe, you would not, I would not want my children to get married to pagans in Europe. People in Europe were worshipping fire and all kinds of other things. So people married within themselves, as was the case, by the way, in many, many families across the world. People were not mobile as we are nowadays, so people tended to marry within their own communities. And what happens is, when a genetic mistake happens, a breakdown of the DNA or a mutation, this tends to be magnified if you're marrying within the same population through a phenomenon that's called endogamy. It's not only limited to the Jewish population, it's also very common amongst Catholics, used to be very common amongst Muslim families, especially in the Middle East. So genetic information nowadays can be tracked, and we've gotten so good about actually deciding the time that some of the mutations known in certain populations have actually developed, some of which started in the year 850, in the 9th century. Gaucher's disease, for example, the first mutation was in 850, and so on and so forth. I'm not going to go over all of this right now. Now, for those who are not students of science, what are genes? Our cells are formed by, our cells are actually blobs of protein, if you will, the middle of which is a nucleus, which is the master that moves the cell, tells the cell to produce milk if it's a breast cell, to transmit electric current if it's a nerve cell. That all happens in the nucleus. The nucleus is made of chromosomes that carry your genetic material, that make you who you are. And the genetic material comes half of it from mom and comes half of it from dad, and so on and so forth. It really never, it gets diluted as we get married into other families, but it never dies. Unfortunately, through that process of transmission and with the breakdown of the chromosomes to be split into different cells, mistakes can happen in the division. God created us with 2 genes that actually correct these mistakes. These are the BRCA1 and the BRCA2 genes. These genes, amongst other genes, but these are the 2 main ones, happen to live on chromosomes 13 and 17. We have 23 pairs of chromosomes. So these 2 genes live on chromosome 13 and chromosome 17 for BRCA1. BRCA2 lives on chromosome 13. Now, needless to say, all of us carry chromosomes 13 and 17. This has nothing to do with the X and Y gene that makes us men and women. That's important because if you have a mutation in BRCA1, change. Mutation means a change. If you have a change in BRCA1 or BRCA2, you could be getting this from either mom or dad. This is not just limited to the sex genes. It has nothing to do with the sex genes. Now, I don't want to scare everybody. The majority of breast cancer that I see in the clinic has absolutely nothing to do with genetics. It is only 1 to 5% at most. 7%, 7 out of every 100 cases of cancer that we see, there are genetics. So not all breast cancer is genetic. It's hereditary, it's because of change in the gene, but it doesn't necessarily have to be inherited. Can there be some Jewish individual, man or woman, who develop cancer that is not necessarily inherited? Absolutely. We see this all the time. We counsel hundreds and hundreds of women from all backgrounds, including Jewish ladies, and we do genetic testing and we're not able to find the gene. Because, being a woman puts you at risk of getting breast cancer. Being a man puts you at risk of getting prostate cancer. It's one of the commoner cancers that happen, and many people develop prostate cancer without knowing about it. In Mike's case, he was aware of it, and he's a young man. Generally, prostate cancer is a disease of older individuals, people above 70 years old. But if it's genetic, you need to be paying attention because it can happen at a younger age. So not to forget, the majority of cancers are not actually inherited. It is only 7%. But I do not want to fool this group. The BRCA1 and the BRCA gene mutations are carried by 1 of every 40 Ashkenazi Jewish individuals. The same genes are carried by 1 in every 354 non-Ashkenazi Jewish individuals. So 1 in 40 versus 1 in almost 400. So the risk of carriership in an Ashkenazi Jewish individual is high enough, and that's something that I was asked to talk about because it's actually common knowledge. It was just published in 2014. If you are Ashkenazi Jewish, you have the right, and insurance companies will cover this, you have the right, in my opinion, the jury, to go to your primary care physician and say, I want to be tested. And your insurance company will cover that. The risk is 1 in 40. So insurance companies decided that this is the way to do it. Because if your risk is 1 in 40, and the families are small, I mean, who has 6 kids nowadays? Very few people. So, and people live all over the country, and some families are overseas, and some families are here. So you actually don't know the family history. So just by the fact, the knowledge that you are Ashkenazi Jewish, you would qualify for genetic testing. There's a big study that was published from Israel this year, where they went and looked at healthy males who are more than 30, and they tested them, and there was no family history, and they established that despite the absence of family history of cancer, carriership was high enough that you have to be, that the testing is definitely an option. It has nothing to do with living in Israel. This is, as we said, it doesn't matter where you go. We carry who we are with us to wherever we go, and we definitely give these genes to our children. Testing in general costs around somewhere between $3,000 to $5,000 in the United States. It is covered by insurance, as I said that before. I fill a form, we send that to your insurance carrier, and we make sure that the testing is covered. And as I alluded to earlier, it doesn't have to be done today. Think about it, get informed, obtain a consultation, take the information with you home, talk to your children, bring your children again and talk to us again, talk about risk reduction in modification of lifestyle, talk about prevention short of surgery, and then make an informed decision. There's no need to rush. There's no need to expedite any of that information. Is it just BRCA, as everybody says? So BRCA, by the way, stands for breast cancer. So it's breast cancer 1, breast cancer 2 gene. There is a breast cancer 3 gene. And more importantly, now we realize that there's a lot of genes that should be tested for or can be tested for that are not BRCA1 or BRCA2 that live on chromosome 13 and 17. We decided to kind of limit the discussion to this group, to BRCA1 and BRCA2, because these are the commonest genes or commonest mutations in the Jewish population. So much so that there is a panel that's called a Jewish panel, where if I have somebody that tells me I am 100% sure I'm Ashkenazi, and by the way, Ashkenazi means German, Eastern European, somebody who comes from that part of the world, and there's no doubt in your mind that you're Sephardic or from the Middle East, then I can, to save money, send just these 3 genes. Generally, I don't do that. Generally, I send the whole BRCA1 and BRCA2. I've tested a woman who's Catholic and to find out that she's a carrier of one of the Jewish mutations. She did not know that she's Jewish. She did not practice the Jewish faith, but she's actually Jewish. Ethnically, she is. As you know, many people who crossed the Atlantic, escaping from the Holocaust, decided not to tell the rest of the world that this is their background. So there may be a lot of people who are out there who actually have an ethnic background as being Jewish, but do not practice the faith itself. So in general, to be comprehensive, we send the whole mutation. There are 3 common mutations. The cost is less. The cost is about $700 or so. One other thing that needs to be known, and in Mike's story, this was very profound. The mom and dad both carried a different BRCA mutation. They're not relatives. Each one of them is Ashkenazi Jewish, I assume, and each one of them brought with him the inheritance from their family. Now, it is very important to know which mutation the child inherited in order to be testing for that particular mutation. Because it's quite possible that mom, let's say, and I don't know the details, I don't remember, it's been 10 years, Mike, we're both getting older. So I don't remember which gene and which side of the family was passed, but generally whatever is passed true, meaning it will be the same gene. So if you know of a cousin in Seattle or in California that was tested, all they need to do is to send you the name of the mutation, and it really doesn't require a lot of work. Everybody who comes through the genetic center at the University of Toledo, which is, Mike was asking me, do you still do this? Yes, we still do that every Wednesday. We give them a report with the name of the mutation, and we offer producing a detailed report, usually somewhere between 5 to 10 pages. We offer to send that back to the primary care physician if the patient is interested. If not, then we give the patient a copy, and it's their information. It's their responsibility to disseminate that information. Now, why is that important? Because as Gayle's story reveals to us, this is preventable. The risk is so high if you're a carrier, it actually bypasses not having had kids, all these kinds of having taken the pill for a long time or taking hormone replacement therapy for a long time. That all fades in comparison with if you are a carrier of a mutation in your cells that makes the cells unable to correct mistakes. The chance of getting cancer is close to 70% in a lifetime. It's not 100%, but it's close to 70%. I, for one, if I know that sometimes ignorance is bliss about a lot of things in life. I think God is so kind to us that He doesn't let us know about everything that can happen to us. For one thing, He's kind to us about not letting us know the day we're going to die, because otherwise I don't know how we're going to be able to get up and go to work every day. But God is also kind to us by letting us know about things that can be prevented. This, by no means, have to be a curse. There are very concrete things that have been tested throughout the years. The knowledge of this field has been around since 1994. So that's 20 years worth of knowledge. And many centers across the country are studying this, keeping track of families. There's a lot of chance for you to be proactive in the prevention. Surgery, as Gayle said, is not for everybody. Not everybody is willing to have bilateral mastectomy with reconstruction. Now, I feel a little more strongly about removal of the ovaries and the fallopian tubes. Bilateral salpingo-oophorectomy, especially after the family has been completed, before menopause is reached. So, it's tricky. It has to be done in the late 30s, early 40s. Now, if we're not thinking about those of us who go to school forever and start having kids, very late in life. So, sometimes you wonder if this is all smart, the way we've changed our lives in this day and age. I think pregnancy is a condition of being young and youthful and healthy. I don't think that knowledge of a genetic mutation, that's my personal opinion, should prevent one from having kids. There is autism in my family. My kids worry about that sometimes. I don't have an autistic child, but there is autism in the family. My kids are going to get married. My nieces who have a brother who's autistic are going to get married as well. These genes are so common. There's a lot of intervention that can be done early. True life changes when you have an autistic child, just as life changes or may be lost if somebody develops cancer. But in my opinion, that's no reason for people not to produce and have more children. But they need to be smart. So if you're a woman who's a carrier, even if you know that you're a carrier, as long as your spouse knows that, there's, in my opinion, no reason not to have children. And once you're done, by the way, having kids is kind of protective from breast cancer as well. Once you're done having kids, you could opt to have the ovaries removed in your early 40s. If the ovaries are removed in the early 40s, this cuts the risk of ovarian cancer by almost 100%, 99%. The risk of ovarian cancer is eliminated. That cuts the risk of breast cancer by 50%. Removing the source of hormones before one has reached menopause cuts the risk of breast cancer by 50%. You couple that with getting an MRI every year, which, by the way, insurance companies since 2005 will pay for an annual MRI for anybody who's a mutation carrier, regardless of their ethnic background. You add these two together, you've cut the risk of breast cancer by 90%. If you're somebody like Gayle, or that Bob would be driven to pieces every time Gayle gets an MRI, that's actually a very individualized decision. And I have encouraged some patients to do exactly the same, now that I know what kind of patient my patient is, the psyche. So these decisions take a long time. They cannot be rushed. The process of counseling takes an hour. We sit and go over all of this and we say, if you're positive, this is what we need to know. If you're negative, this is what we need to do. One other thing, there are things that are called variants of unknown significance. So you really don't want an amateur to test you, because typically what happens is somebody tests and they find what's called an amateur of unknown significance, and then they call and they say, Mohamed, I'm sending somebody to you because I don't know what to do with this. So find a place that does this on a regular basis. There are 3 or 4 places in town that do that, and if you have any concerns, pick up the phone and talk to us. Again, I want to reiterate again that HIPAA prevents me or any healthcare worker from disseminating that information, and that the process itself is all done in a very confidential way. I'm going to stop here to leave some room for people to ask questions.
All right. Very good. Thank you very much. I'd like to thank the panel for sharing stories, journeys, and empowering all of us to take responsibility for ourselves and for our families in regards to our background. So thanks again for everything. I'd like to switch gears a little bit and talk a little bit more how this morning came to be. I'd like to recognize Macy's in regards to their participation in today's event. But just a little history behind our collaboration. At the very first meeting last April, after choosing the title, What's in Your Jeans, giving away pairs of blue jeans was discussed as an incentive to draw the community together for this important event. Obviously, it was a play on words. The committee recognized that the community and a corporate partner was needed. And without hesitation, everyone shouted Macy's would be the perfect fit. Jeans fit, get it? No? No? Okay. I'll leave the jokes for someone else. And Macy's is known for their legendary commitment to the community, this just being one of many funding priorities. The relationship with Macy's has been great from day one. We move past the getting to know you stage, and we become great friends. We're so proud, lucky, honored, grateful for Macy's cooperation and collaboration. It is my pleasure to ask Michael, Lannie, and Carla from Franklin Park Macy's to join us this morning for this very special presentation.
We're just honored to be here and be part of this. So, and we do have a check for a donation. So, and we just thank everyone for thinking of Macy's and just to be part of the community, and we do really appreciate the opportunity to learn so much about this today. Anything else you guys need, just let us know. So we're happy to help. Thank you.
Thank you. Thanks again to Macy's. Without you, we couldn't have pulled this off. As advertised, a $36 gift certificate towards a pair of blue jeans will be given to the first registered attendees. One gift certificate per family. The lucky winners will be listed in the December Jewish News. All right, now we'll switch gears and start to prepare for the question and answer session. And this would be the right time to raise your hands if you have questions for the panel. A runner will come by, pick up your questions so we can present them. Before we get to your questions, there's one more thing. Dr. Mohamed. I'm going to present you with the Judaica honey pot. Now, this represents the sweetness you have provided our community throughout the years. You have graciously, generously shared your time, your knowledge, and your passion, and most of all, your genuine, caring, and kind persona. You have endeared yourself to all of us. Please accept a token of our appreciation, your profound gratitude and admiration. Okay. So while we are collecting some of these questions, we'll just start with the that I have here. So, does everyone who is Ashkenazi get tested? And if so, what age? Primary care physicians start the process? Should it go through a genetic counselor? Your thoughts?
As I said, Dave, the carriership rate is 1 in 40. So that's high enough for most insurance companies to decide that yes, if you know that you're Ashkenazi Jewish, you have the right to at least request a counseling session. Most primary care, I cannot do a good consultation about ulcerative colitis. You were teaching me this morning a lot about ulcerative colitis. My knowledge is not up to date. So I truly believe that there are people who do this day in and day out and are more prepared and more equipped to answer questions that people have. One other thing, most of our patients who come for genetic testing or counseling have done some reading, so they have questions and they have a lot of knowledge, so you need to be prepared. So if you're a primary care physician with enough knowledge about that and you want to start the process, by all means. But if not, as I said, in every major hospital system in this town, there is a genetic service. Now, I think we do a great job, but we're not the only people in town who do this. But if anybody is interested in having an appointment with us, they can call the cancer center and they sit down for what's called a consultative session, which is about an hour. As I was telling you earlier in the day, we see the patients in the clinic itself, but we also have a huge room that can accommodate 12 family members and extra chairs to be pulled. And I've done that before. I've had family members all come at the same time, and these are usually prolonged consultations, but it's good because then everybody understands what the risk is, it's not blown out of proportion, and people go home, make a decision, and then they come back, and we usually would prepare all the forms, and they come and get the blood test, and they're brought back 6 weeks later, because that's how much time it takes. I've actually gone to the company, one of the companies that does the testing itself. It's a very laborious process. You understand the implications. If you walk to somebody and say that you're a carrier of a gene that causes cancer, they may go and decide to have all kinds of surgery, and then you call them a month later and say, oops, I was wrong. So there's no oopses in this. The sample itself is run twice. That explains the cost of $5,000. It used to be $3,000 when we first started, but of course it's getting higher. They run the specimen twice, and then manually somebody sits and looks at all of this. So when there's a test out there, we know that the test is accurate. So bring the family 6 weeks later. I rarely disclose results on the phone, except that the results are negative and the patient needs it for something else. So sometimes patients who are diagnosed with breast cancer want to know if they're carriers or not. Because they decide if they're carriers, they're just going to have bilateral mastectomy. If they're not, they're just going to have a lumpectomy, let's say. So if she's negative, I'll tell her that on the phone. But if somebody is positive, this is not something that you can disclose on the phone. So in general, I discourage from giving information on the phone. People react differently. Some people, I mean, Gayle put it beautifully. She had to drive. She probably was in the stage of shock. Her husband understood all of it and was calculating, this is what's going to happen. People react very differently to this. Sometimes people are relieved. They kind of knew that something was going on. Ms. Mostov, I'm sure there are people in your family who said, finally, there's an explanation for this. Sometimes people cry. Sometimes there's a survivor's guilt. So a sibling who's negative, who says, but I look like mom. I thought I'm the one who's going to be a carrier. They react, you have to be prepared. And we are usually prepared in the cancer center, and that's why we make it an hour. Because you can't rush any of that stuff. Whether it's results or a consultation, it takes a long time to do this. Can primary care physicians do it? Yes, but you and I know what primary care, the pressure to see a lot of patients is like, so it's very hard to put aside that type of thing. I'm always in contact with the primary care physicians if my patient so wishes, because they need somebody who's their quarterback to make sure that they get their MRIs, to make sure that they get tested. I probably see them once a year, but there's somebody who is their support person on a regular basis, and that's the PCE. I hope I answered your question.
Okay, yes, you did. Thank you very much. So, if there are two parents, and both parents test negative, can we reassure children and so forth that they too will be negative and therefore they'll never have to be tested?
Okay, very important question. If the family history is so impressive that you are pretty convinced that there is a mutation, your best person to test is an affected individual. I think if you remember this today, that'll be the success. It is always best to test somebody who has developed cancer. To test somebody who has not developed cancer may not tell you if this is a true negative or not. So if there's a pedigree, and there's Aunt Millie who lives in South Dakota, who was 45 and she's a survivor, this is the particular individual that needs to be tested. If that person is negative, it is very unlikely that there's a mutation in the family. But if I'm testing mom and dad, and both mom and dad are healthy, and they're both negative, you can never be sure that there is another mutation in the family or not. Their kids will not have a mutation for sure. That's their kid, so they're not going to have a mutation. Will they ever be tested for cancer? Absolutely. They have the population risk like everybody else. If you live to be 70 or 80, you have a 1 in 12 risk of developing breast cancer. That doesn't go away. The risk is much more amplified if you're a carrier of a mutation. It's about 70%.
All right, thank you. I'll ask one more question, then we'll open it up to the audience. For those of us who were Ashkenazi, we think, and married someone who's Sephardic, how does that play into things? I guess it's a little bit different because this is a disease of Ashkenazi Jews. Recommendations, if it's not quite as clear.
Yeah, so yes, there are. So the 1 in 40 carriership is for Ashkenazi Jewish individuals. So if I'm Ashkenazi, but my spouse is not, then I can get tested because half of my children would get my gene. There's a 50% chance. And by the way, that's a misnomer when we say half of my children will get my... I'll tell you the better way of doing this. Saying this, with every pregnancy, there's a 50% chance that this offspring will be a carrier of a mutation. So if you're lucky, you can have 4 children, none of whom has the mutation. Because with every pregnancy, it's 50-50. So it's a coin toss. But on average, usually 2 of the 4 will be carriers. But it could be 3 of the 4, and it could be all the 4, and it could be none of them. So yes, being Ashkenazi, even if you're married to somebody who's not, that means nothing. Your chance of passing a mutation, if you're a carrier, is 50-50 to each child.
Very good, thank you.
Okay, so when they do the prostate biopsy, it's basically a hit and miss. I mean, if there's a lesion there and they do the biopsy and they just don't hit the right spot, they can miss it, even though it's there. Particularly with small cancers, it's very easy to miss, and this is not uncommon to happen where you can have a negative biopsy. So, I had 3 biopsies, and it turned out, we found out afterwards that the reason that my first 3 biopsies were negative is because 85% of prostate cancers are in one area of the prostate, which is where they usually do the biopsies. Well, turned out my cancer was not in the area of the prostate where they normally do the biopsies. It was in a different area called the anterior lobe of the prostate. And that's not an area where they typically do the traditional biopsies. Well, it turned out when they had the MRI, the lesion actually showed up on the MRI. So they knew exactly where to go to do the biopsy, and then the 4th biopsy was the one that turned out to be positive, and that's how they were able to make the diagnosis.
Okay, very good, thank you. A question for Dr. Mohamed. Is the BRCA1/2 gene common among Eastern Europeans who aren't Jewish as well, or is it simply an issue among Jews?
The BRCA1 and BRCA2 gene mutations happen to everybody. They happen to all different types of populations. There are 3 mutations in these, and there are multiple changes in this gene that can happen. But there are 3 that are called founder mutations that are very common in Ashkenazi Jewish individuals. So when we test people for BRCA1 and BRCA2, we don't necessarily limit this to Ashkenazi Jewish individuals. It's just that the rate is a little bit higher in individuals of Ashkenazi Jewish background.
Very good, thank you. And again, for Dr. Mohamed. Okay. Where is the best place to get genetic counseling in the area? And under what circumstances would you have an annual MRI as part of that follow-up?
That's the easier question to test. So annual MRI is approved since 2004 by ASCO, the American Society of Clinical Oncology, on an annual basis, paid in full for anybody who's a mutation carrier. And that also includes people who've already had bilateral mastectomy, because you can see through the reconstructed breast, be it a tram flap or also be it a prosthesis. You can see behind and you can see what's going on, because you never really remove 100% of the breast tissue. And, you know, I'm a humble person, but I'm not that humble. I think we do the best job.
Okay, well, you were up there, and we know that commercial insurance under the right setting covers this. What about Medicare?
You need to it's not called the white line, but you really need to submit the appropriate information to the insurance company. And having done this for the last 15 years, we know how to do this. So if the right information is sent, it will be covered for. Medicare definitely covers for that.
Okay, fair enough. And this is a good question. Okay, again, I forgot the one already. What would you recommend for individuals who are adopted and they don't know their
Yes,
family history?
yes, and that happens a lot in my clinic. Unfortunately, I am certain that there are individuals who are of Ashkenazi Jewish background who do not know that. They would qualify for testing if you know you're Ashkenazi Jewish. But let's say you're Ashkenazi Jewish, got adopted into a family that's not, and you would not know about that. So that you would not. But I have tested many, many individuals. That alone, being adopted, puts you at a more, insurance companies are more likely to be sympathetic to your history, even if there's just 1 or 2 cancers that you're aware of.
Okay, thank you very much. Other questions to submit? Are there any? Okay, well, you know what?
David. There was a question.
Right, no, we have, question? Yep, you can just,
I wanted to know, does insurance cover testing of the BRCA gene in Ashkenazi Jewish men?
Oh, absolutely.
Men and women?
Absolutely. Like I said, this is not a sex-linked mutation. It's an autosomal dominant. Absolutely. Testing is approved for both men and women. Ta-da! We tested Dr. Gordon, and we test men all the time.
Even if there's not a history of the BRCA gene?
Absolutely, absolutely.
So would you go to your primary care then?
You can discuss that with your primary care physician and ask for a referral.
this is for Gayle. To get through what you've been through, where did you go to receive group support for BRCA gene mutation?
Well, as I said, I went up to the University of Michigan. When I did this in 01, when it all started in 2000 and then 2001, I was not aware of any support. As a matter of fact, when we came home from the University of Michigan, I started telling friends that I had this and I had decided to have these prophylactic surgeries. There were several friends who questioned my decision and said, why are you cutting out parts of your body when you don't have cancer? It was really difficult for me, and as I said, I'm a pretty strong person, but knowing that close friends were questioning and thinking that I'm nuts was very difficult. But I just said, this is my life, this is my body, I have to do what's good for me, and good for Bob, and good for my kids. I had no support. Right now, there are support groups. There's an organization called FORCE, F-O-R-C-E. I don't know what it stands for. I know the F stands for facing, and that's about as far as I've gotten. It's a wonderful organization. It's a great website with a lot of links. It talks about all the current research. It's really a good website. I am also on a closed Facebook group for just BRCA men and women. And it's all over the world because Facebook's all over the world. And I have to tell you that I am amazed at the amount of information that our doctors have. And believe me, they don't have enough. But compared to the physicians in other countries, it's just like night and day. And I'm also amazed at the young age of the mostly women that are on this Facebook page. There are many women in their 20s. Most of them are actually in their 30s. And they're just going through it. And they have no clue. I mean, one girl wrote, so if I have my mastectomies, does that mean I don't get my period anymore? I mean, these young women just have no clue. But with this Facebook page, I'm constantly writing in you know, trying to explain my experiences and some of the things. We actually just last night had a mother write. She has a special needs daughter who is 7 years old. She had been tested for all kinds of things just to figure out his special needs, and she came out BRCA1 positive. And the child is nonverbal, so the mother wanted to know, is she in pain? And what does this mean? So, you know, I wrote in and tried to say, she's not in pain. This is, you know, this is a mutated gene and whatever. So there's a lot more out there now, but in 2000, 2001, there wasn't much of anything.
Question, Dr. Mohamed, you brought up two different tests. One was the blood test, one of them was from the buccal mucosa. How effective is that test? Could you comment on that?
We don't do this. I think blood test is, in my opinion, a much more dependable test, and that's the way we do it. And blood cells, red cells do not carry cells, so it's the lymphocytes, it's the white cells that are tested for. Red cells have lost the nucleus during their formation, but it's the white cells that are separated, broken down, and the chromosomal analysis is performed on the lymphocytes.
Okay.
But you could do the same from the bucket. See, the gene is carried in each and every cell in the human body, but blood cells are more dependable and they're more durable as the testing is performed.
Okay, all right, thank you. How close a family relationship should be to cause concern with cancer before the age of 50?
So, when you sit in the genetic counselor's office, a family pedigree is drawn. So the more information we ask our patients, those who have an appointment, to keep asking and get as much information. So typically what we're looking for, any family member, as long as they come from the same side of the family. So you need to know who's maternal and who's paternal. So mothers, sisters, daughters, cousins, first cousins, children of first cousins, grandparents, great-grandparents, any family history. Your brother's wife is not family. She's family, your sister-in-law, but she's not family. So I'm talking about any blood relative, and it's very important to sort out mom and dad side of the family. We don't mix these together. So it's a blood relative, not a marriage relative.
Okay.
But anybody.
Okay, thank you. We have time for a few questions.
My question is this, perhaps I might know, and that is, if a male is tested positive for BRCA, do typically sometimes they follow through and have their prostate removed as a preventative measure, such as women have doing what, mastectomies and so forth?
No. There's complications associated with prostate surgery, and nobody in their right mind would do a prophylactic prostatectomy.
So the relative risk is only 3 to 4.6 times more. So your risk of developing, if you're a carrier of the BRCA2 mutation, it's 3 to 4.6, so 5 times more than the rest of the population. This is not a minor surgery, and as Mike said, it has side effects. So.
Okay, time for a few more questions. In the back.
On average, as a new patient, how long would it take to get an appointment for genetic counseling?
This is free marketing. Couple of weeks.
Okay, yes?
In the past, people were really concerned to get genetic testing because they might lose their insurance. Have the insurance regulations now changed, prevent you from losing your insurance if you test positive?
I think the explosion came after the human genome. Technically, in the next few years, you should be able to pay, you can pay somewhere in the neighborhood of $400 and actually know exactly what kind of diseases you will develop in the course of your lifetime. I'm not sure that many of us will do that, but there's so much that's available now about all of us that the insurance companies will not discriminate. And they will not discriminate because this is not a disease state. Being a carrier of a mutation is not a disease, it's not a pre-existing condition, if that's what you're thinking of. They're not going to drop you because you are a carrier of a mutation, and you don't have to disclose this to them anyways.
You got it.
And I will not. I could lose my license. That's HIPAA violation.
If someone is positive for melanoma and they're an Ashkenazi Jew, should they be tested?
I'm glad that Gayle brought that up. There's a lot of less strongly associated cancers in certain families, as we've seen. In certain families, there may be one type of cancer that's more commonly seen than another. Melanoma continues to be an environmentally related disease. So in certain types of families that are called melanoma/pancreatic families, there's some association with pancreatic cancer and melanoma and BRCA too. But if we're going to test melanoma or skin cancers are the commonest malignancies in the United States. There are 10 million survivors of cancer in the US, most of whom are skin cancer survivors. So we're not going to test every person with melanoma. But if you tell me that there are melanoma cases in the family that are young, that there's a pattern, that we see more than one individual, people who are not sun worshippers, then definitely that would be an indication to at least get a consultation. But to test just because of a family history of melanoma in one individual, insurance is not going to pay for that.
But if they're Ashkenazi Jew, different set of
Then I'll dig a little bit more,
Right.
yes. And they can be tested just on the basis, even if there's no melanoma, just on the basis of being Ashkenazi Jew.
Right. Okay. Time for two more.
If the mother's been tested and has the BRCA gene, and she has a daughter, the daughter was tested, say, in her early 20s, and comes out negative, should she be tested again when she's older since the cells continue to break apart?
Beautiful question, excellent question. This daughter is a true negative. This is the only person who can know for sure that they are negative. Their mother is tested, we know that there's a mutation, and they're tested. The only caveat is if dad is a Jewish individual and has a mutation, which we don't know, right? But in general, we have a mutation in the family, and you tested this daughter, and this daughter is negative, that gene is not going to change whether you're 10, 2, 20, or 90. We're done. This individual does not need to get MRIs on a regular basis. She will get her first mammogram at the age of 40 like everybody else and has general follow-up guidelines. That's a true negative. That's the value of testing. This is Mike Gordon's daughter, right, Mike? So your daughter does not need to be tested again.
Great. And one more question.
What's the difference between BRCA1 and BRCA2?
Okay, they are two different, so as I said, I wish I could show you this. The human chromosomal set is 23 sets, 23 pairs of chromosomes.
The differences that cause different kinds of cancer?
No, they're both associated with breast and ovarian cancer. There's some extra cases of prostate cancer and melanoma cases. Ovarian is more likely to happen with BRCA1. The cancers that happen with BRCA1 tend to be triple negative. With BRCA2, they tend to be, I'm talking about the breast cancers, they tend to be driven by hormones. But in general, the risk for cancer is very similar. They just live on different chromosomes. Nobody carries both of them. You're either a carrier of BRCA1 or BRCA2. And in a certain family, if there's a BRCA1 gene, then everybody will be a carrier of BRCA1. It's not like one person will be one, it's the same gene. But the risk of different cancers are slightly different, and when somebody is diagnosed, we send them home with a sheet that says, this is your lifetime risk of breast cancer. Ovarian is more commonly seen with BRCA1, for example, than BRCA2. But they're very similar.
Great, thank you very much. So before we depart, everyone will be getting a handout on the way out, which is a call to action. And this call to action is to encourage everyone here to investigate your family's history, and not only for your family, but also sharing those results with your physician and to be proactive for yourselves, as we've heard today. So a few points. Knowledge of your family history is power and it saves lives. Both sides of the family are equally matter. Early or bilateral history of cancer in an individual or having an Ashkenazi Jewish background warrants a discussion with a genetic counselor to better understand individual cancer risk. Number 3, if a cancer-causing mutation is detected with testing, as we talked about today, typically a blood sample, many risk reduction options are available, not always requiring surgery. And last, counseling and testing are both covered, as we talked about, by most insurance plans and appropriate candidates, and there are methods of screening for early detection. I would like to thank the panel. I'd like to thank for everyone who helped put this together today. Please, on your way out, see Beth, Fady, for one of these handouts. This information could save your life. Thank you.